Welcome to OET Answers.
Occupational English Test. OET Answers Practice Test, Listening Test. This test has 3 parts. In each part you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. You hear a urologist talking to a patient called Benjamin Halls. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Please come in. It's Mr. Halls, correct?
Yes, that's right. Benjamin Halls.
Nice to meet you, Mr. Halls. I understand you've been referred to me because of some concerns regarding your urinary health. Can you tell me what's been going on?
Well, I've been experiencing blood in my urine on and off for about 2 months now. At first, I didn't think much of it, but it's been happening more frequently. I also feel this weird burning sensation when I pee. My GP said I should see a specialist.
It's good that you came in. Blood in the urine, known as hematuria, can be caused by several factors, and it's important to investigate. Along with the burning sensation, have you experienced any other symptoms? Pain in your abdomen or lower back, for example?
Actually, yes, I've had some discomfort in my lower back, but I thought it was just from sitting too long at work.
That's understandable. Symptoms like these can often overlap with other conditions, so it's important to look at everything together. I've reviewed your medical history, and based on your age and these symptoms, we need to consider a range of possibilities, including bladder cancer.
Bladder cancer? I didn't think it could be that serious. What makes you suspect that?
I understand this can be worrying, but let me explain. Bladder cancer is relatively common, especially in men over 55, and one of the primary signs is blood in the urine without much pain. The burning sensation and back discomfort could also be linked. However, we need to run tests to confirm anything. At this stage, we're just covering all our bases.
What kind of tests are we talking about?
We'll start with a cystoscopy. That's where we use a thin, flexible tube with a camera to look directly inside your bladder and check for any abnormalities. We'll also conduct a urine cytology test, which examines cells in your urine under a microscope to see if there are any cancerous or abnormal cells. If we find anything suspicious, we might need to take a biopsy to get a closer look at the tissue.
That sounds pretty invasive. Is the cystoscopy painful?
It's understandable to feel anxious about it, but the procedure is typically done under local anesthesia, so you shouldn't feel much more than some discomfort or pressure. It's a quick procedure, usually taking less than 10 minutes. We use it because it gives us a clear view of the bladder, which is essential for an accurate diagnosis.
And if you do find something, what happens next?
If we do find signs of bladder cancer, the next step would depend on the stage of the cancer. Bladder cancer is often caught early, which is a good thing because early-stage bladder cancer can be treated quite effectively. Treatment might involve removing the tumor during a cystoscopy, followed by intravesical therapy, where we administer medication directly into your bladder to kill any remaining cancer cells. In more advanced cases, treatments might include surgery, chemotherapy, or immunotherapy. But again, we need to wait for the results of the tests before discussing specific treatment options.
I see. What causes bladder cancer? I don't smoke, and I thought that was the main risk factor.
You're right, smoking is the most common cause of bladder cancer. However, it's not the only risk factor. Chronic bladder inflammation, exposure to certain chemicals in the workplace, and a family history of bladder cancer can all contribute. Even people without these risk factors can still develop the disease. That's why it's important to get checked when symptoms like yours appear, regardless of lifestyle factors.
How serious is it if it turns out to be cancer?
Bladder cancer can range in severity, but the good news is that when it's caught early, it's highly treatable. About 70 to 80% of bladder cancers are non-invasive when first diagnosed, meaning the cancer is confined to the inner lining of the bladder and hasn't spread to other layers or organs. In those cases, treatment is very effective, and many people go on to live healthy lives after treatment. It's only when bladder cancer becomes invasive or spreads that it becomes more serious and harder to treat. That's why early detection is so important.
How likely is it to come back, even if we treat it successfully?
Unfortunately, bladder cancer does have a relatively high recurrence rate, even after successful treatment. For non-invasive cancers, the recurrence rate can be as high as 50 to 70%. But we keep a close eye on patients who've been treated for bladder cancer through regular follow-up cystoscopies and tests.
Extract 2, questions 13 to 24. You hear a otolaryngologist talking to a patient called Mr. Johnson. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mr. Johnson. Please come in. I've reviewed your file, and I see we're here today to discuss the ongoing issues with your nasal congestion. How are you feeling?
Hi, thanks for seeing me. It's been frustrating. I've had this constant feeling of being blocked up for months, and I just can't seem to breathe properly through my nose. It's making it hard to sleep and focus.
That sounds difficult. Let's take some time to go through your symptoms and what might be causing them. From what you mentioned, this nasal congestion has been persistent for quite some time, correct?
Yes, it's been about 6 months now. At first, I thought it was allergies, but antihistamines didn't help much. I even tried nasal sprays, but they don't seem to make a difference either.
6 months is a long time to deal with this. You also noted on your intake form that you're experiencing a reduced sense of smell. Is that correct?
Yes, I can barely smell anything these days. It's really strange, everything feels muted, and even when I try to take a deep breath through my nose, I can't get much air in.
That can certainly be concerning. Along with congestion and the loss of smell, have you noticed any other symptoms like facial pressure, headaches, or postnasal drip?
Yes, I've had a lot of pressure around my forehead and eyes. It comes and goes, but it's there most days. I also have this constant drip down the back of my throat, especially when I lie down at night.
I see. Based on the symptoms you've described, persistent nasal congestion, reduced sense of smell, facial pressure, and postnasal drip, there's a strong possibility that you may have nasal polyps. Have you ever heard of them?
I've heard the term, but I'm not entirely sure what they are.
Nasal polyps are non-cancerous growths that develop in the lining of the nasal passages and sinuses. They're often associated with chronic inflammation, which could explain the persistent congestion and the pressure you've been feeling. They can vary in size and may grow large enough to obstruct airflow, which would explain why your breathing feels blocked.
Oh, wow. So they're just like little growths in my nose?
Exactly. They're soft, painless, and typically not dangerous on their own, but they can cause discomfort and make breathing difficult. The fact that you've had these symptoms for 6 months suggests that we should investigate further.
What causes them, though? Could it really be just allergies?
Allergies can be a contributing factor, but nasal polyps are usually linked to chronic inflammation of the nasal passages. Conditions like chronic sinusitis, asthma, or even aspirin sensitivity can also increase the likelihood of developing polyps. Sometimes they can occur without any clear cause.
So what do we do next? Is there a way to confirm if I have these polyps?
The next step would be to examine your nasal passages and sinuses more closely. I can perform a nasal endoscopy, which is a simple and non-invasive procedure where we use a small camera to look inside your nasal passages and check for any signs of polyps or other abnormalities. It's not painful, though it can feel a little uncomfortable.
That doesn't sound too bad. What if I do have polyps? How are they treated?
There are a few treatment options, depending on the severity of the polyps. We usually start with medications such as corticosteroid nasal sprays, which can help reduce the size of the polyps and relieve your symptoms. If that doesn't work, or if the polyps are large, we may consider oral corticosteroids for a short period.
And if the medications don't help?
If the polyps don't respond to medication, or if they're causing significant obstruction, surgery may be necessary to remove them. This is usually done through a procedure called endoscopic sinus surgery, where we use a small camera and instruments to remove the polyps and clear out the nasal passages.
Is surgery risky?
Like any procedure, there are risks, but endoscopic sinus surgery is generally safe and minimally invasive. The recovery time is usually short, and patients typically experience significant improvement in their breathing and other symptoms afterward. However, it's important to note that polyps can sometimes recur, so long-term management is key.
How can I prevent them from coming back if I do end up needing surgery?
After surgery, we usually recommend continuing with steroid nasal sprays to reduce inflammation and prevent new polyps from forming. Managing underlying conditions like allergies or asthma is also important. In some cases, biologic therapies can be used to target the underlying causes of inflammation in the nasal passages.
It sounds like it could be a long process.
It can be, but the good news is that with proper treatment and management, most people experience significant relief from their symptoms. It's important to stay on top of your treatment plan, especially if you have conditions like allergies or asthma that could trigger the polyps to return.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a nurse briefing to a doctor. Now read the question.
Good morning, everyone. Let's get started with the morning briefing. David, can you begin today?
Absolutely. First up, we have a 45-year-old male with no significant past medical history who presents with swelling of the face, difficulty breathing, and a rash after eating shellfish. His symptoms have worsened over the past hour. On exam, he has wheezing, facial edema, and widespread urticaria.
Okay, so next steps.
Given the patient's symptoms and physical exam findings, administering intramuscular epinephrine and providing airway support are the next steps.
Now look at question 26. You hear a senior paramedic giving feedback to a trainee after a training exercise. Now read the question.
About this situation. We need to familiarize ourselves with the equipment before starting treatment. Exactly. And remember, time is critical in a case like this, so knowing exactly how the suction works can save crucial seconds. I wish the design was a bit more intuitive.
Should I have handled the suction, or would someone else typically do that?
It doesn't really matter, as long as it gets done quickly and efficiently.
Now look at question 27. You hear a nurse talking to another nurse about the care of a patient. Now read the question.
Sam, can I talk to you for a moment, please?
Sure, what's up?
I noticed that you've been a bit distant and not as engaged while interacting with the transgender patient in room 5. You seem uncomfortable discussing her post-surgery care, which is a bit concerning.
Yeah, I guess I just don't agree with people changing their gender like that. It's hard for me to offer the same level of care when I feel like it's going against what's natural.
I understand that everyone has personal beliefs, but it's important to remember that our role as healthcare providers is to offer inclusive, non-biased care to all patients. Think about how you would feel if you or someone you cared about was in her position. It's our job to ensure patients feel respected and understood, regardless of their background or identity.
Now look at question 28. You hear a lecturer talking to a student about medical illustration. Now read the question.
Do we have the materials for today's discussion on medical illustrations?
Yes, I've gathered the references, including some works by Vesalius. We're focusing on how his anatomical drawings contributed to medical knowledge, right?
Exactly. His work revolutionized anatomical understanding in the 16th century. But looking at today's digital renderings, there's been a gradual evolution. Artists now use technology to create accurate 3D models and high-resolution images that can show even finer details, so we'll discuss both approaches and compare them.
So, what's the key element that makes these illustrations so valuable?
Well, it's the balance between accuracy and artistic representation. Historically, it was the only way to convey medical knowledge before we had advanced scanning technologies. It allowed physicians to study the human body visually, but modern tools have added precision. The illustrations are still indispensable for understanding complex structures in ways scans can't always show.
Now look at question 29. You hear a medical professional explaining a new protocol. Now read the question.
Hello everyone. Today, I'm going to discuss the new protocol for responding to emergency code situations, particularly code blue, which is triggered when a patient experiences cardiac or respiratory arrest. In the past, our code blue response has been fairly routine, with only the assigned emergency team handling the situation. However, we've seen some delays in response time, and there have been instances where staff in the vicinity were unsure of their role, leading to confusion. As many of you know, time is of the essence in code blue situations, and every second counts. Delays or unclear communication can have serious consequences for patient outcomes. This is why we've updated our procedure to ensure all staff on the unit, not just the emergency team, are fully aware of their roles. The new protocol emphasizes immediate, clear communication across all available staff during the emergency. Each team member now has a defined role, whether it's performing CPR, retrieving emergency equipment, or relaying information to the emergency team. By involving more of the team and ensuring everyone knows their responsibilities, we aim to improve response times and save more lives. Now let's move on to a few details about how this will work during a code blue.
Now look at question 30. You hear two nurses discussing the new protocol for administering medication. Now, read the question.
Bennett, I need to ask you about the new medication administration protocol.
Sure. Sarah, what's the issue?
I tried following the new guidelines, but I'm not sure if I'm doing everything correctly. It's so detailed, especially with recording the dosages.
Yeah, it can be a bit much at first. Have you reviewed the section about logging the medication times and doses in the electronic system?
I have, but I'm confused because I keep getting an alert that says my entries are incomplete, even though I double-check everything.
Did you try contacting the IT team? Maybe it's a system error.
I haven't, no. I thought I might have been doing something wrong, but now I'm not so sure.
Well, if you followed the protocol and are still getting the alert, it might not be your fault. I'd suggest letting the charge nurse know and ask her to check if the system is glitching. She can escalate it if needed.
That's a good idea. I'll send her an email today.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For question 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Extract 1. Questions 31 to 36. You hear a pharmacologist giving a detailed presentation nanotechnology in developing targeted drug delivery systems. You now have 90 seconds to read questions.
Hello everyone, thank you so much for being here today. My name is Sarah Thompson, and I am a pharmacologist and researcher at Oxford University. Today, I am excited to present some groundbreaking research on the use of nanotechnology in developing targeted drug delivery systems. This research has been conducted in collaboration with other prestigious institutions across Europe and with pharmaceutical companies that are working toward the future of medicine. To provide some context, let me start by explaining how traditional drug delivery works. Most medications, whether for cancer treatment or for managing chronic diseases, are administered in a way that allows the drug to circulate throughout the entire body. In many cases, this means the drugs affect both healthy and unhealthy cells, which can lead to numerous side effects. For instance, in cancer treatments like chemotherapy, the drug attacks rapidly dividing cells, but it doesn't distinguish between cancer cells and healthy cells like those in the hair follicles or digestive tract. This is why chemotherapy can cause severe side effects such as hair loss, nausea, and fatigue. One of the goals of targeted drug delivery is to ensure that medications reach the specific area where they are needed most, thereby sparing healthy tissues. This is where nanotechnology comes into play. Nanotechnology involves engineering materials at the nanoscale, typically less than 100 nanometers in size.
To give you a visual reference, a human hair is about 80,000 to 100,000 nanometers wide, so you can imagine how tiny these particles are. Nanoparticles can be designed to carry drugs directly to the site of disease, such as a tumor in cancer patients. These nanoparticles are equipped with molecules that can recognize and bind to specific markers on the surface of cancer cells. Once they bind to the cancer cell, the drug is released directly into the cell, allowing for higher concentrations of the medication where it is needed, while reducing its presence in healthy tissues. This dramatically reduces side effects for patients and improves the overall effectiveness of treatment. The implications for cancer therapy are immense. For example, in one of our studies, we tested a nanoparticle-based delivery system for a common chemotherapy drug called doxorubicin. When administered through conventional methods, doxorubicin can lead to heart damage, but with the use of nanotechnology, we were able to deliver the drug directly to tumor cells, minimizing its presence in the heart and other healthy tissues. This reduced the occurrence of heart-related side effects by over 50%. Another exciting aspect of nanotechnology is its potential for combination therapies. For example, nanoparticles can carry multiple drugs at once, allowing for the simultaneous treatment of cancer cells using different mechanisms. This could lead to more effective treatment regimens with fewer doses, reducing the burden on patients. Now, let's talk a bit about how nanotechnology is improving the patient experience overall. In many cases, traditional drug delivery methods require frequent hospital visits, particularly for treatments that need to be administered via intravenous infusion. With nanotechnology, we are exploring ways to deliver drugs orally or through patches, which would allow patients to receive treatment from the comfort of their own homes. In clinical trials, we've seen promising results, with some patients achieving similar outcomes to those who would have undergone standard infusion treatments. While all of this sounds incredibly promising, it is important to note that we are still in the early stages of applying nanotechnology in medicine. There are challenges that remain, such as ensuring the safety of these nanoparticles in the long term, as well as scaling up production for widespread clinical use. Additionally, we are working to ensure that the cost of these advanced therapies remains accessible to patients across the globe. One of the key areas of focus moving forward is the development of personalized medicine. By using nanotechnology, we can tailor drug delivery systems to the specific characteristics of an individual's disease. For instance, we can use genetic information to design nanoparticles that are better suited to target the unique markers present in a patient's cancer cells. This approach could lead to more effective treatments with fewer side effects, while also improving the success rate of therapies in difficult-to-treat cancers. We are also excited to collaborate with international research institutions and healthcare providers to advance this technology. The potential applications of nanotechnology in medicine go beyond cancer. We are already seeing progress in treating autoimmune diseases, neurodegenerative disorders, and even cardiovascular diseases. By working together, we can continue to push the boundaries of what is possible and bring these life-changing therapies to more patients around the world. In conclusion, nanotechnology is opening new doors in the field of medicine, particularly in the area of targeted drug delivery. By improving the precision of treatment, reducing side effects, and enhancing patient outcomes, we believe that this technology represents the future of healthcare. I would like to thank my research collaborators, our pharmaceutical partners, and the patients who participated in our clinical trials. Your contributions have been invaluable. I am happy to take any questions from the audience now. Extract 2. Questions 37 to 42. You hear a conversation between Emma and Dr. Amanda Brookfield discussing infertility. Now, read the questions. You now have 90 seconds to read questions.
Good afternoon, everyone. I'm Dr. Amanda Brookfield, a reproductive endocrinologist at St. Mary's Hospital, where I've been specializing in infertility and reproductive health for over a decade. Today, I'll be talking about one of my patients, Emma and Luke, a couple who've been struggling with infertility for the past few years. Emma, would you like to begin by sharing a bit of your story?
Sure, thank you, Dr. Brookfield. Luke and I have been trying to conceive for almost 3 years now. We've always dreamed of starting a family, but things just didn't go as we had planned. I'm 34 now, and it's been tough, especially because most people our age already have kids or are expecting. We tried tracking ovulation, eating healthier, and cutting back on stress, but nothing seemed to work. So, after about a year of trying naturally, we decided to see a doctor.
Yeah, we were told by the first doctor we saw to just keep trying, and that it might take time. But after about 6 more months, Emma still wasn't pregnant, and we felt like we needed more answers. That's when we found Dr. Brookfield, and she suggested some tests to figure out what was going on.
Right. After the initial consultation, I ordered a series of diagnostic tests to determine the cause of their infertility. These tests are very routine in reproductive health, and they help us get a clearer picture of the factors that could be affecting fertility. Emma had blood work done to measure her hormone levels, and we performed an ultrasound to look at her ovaries and uterus. For Luke, we ran a semen analysis, which looks at sperm count, motility, and morphology to check for any issues on the male side.
I think it was really eye-opening for both of us to see how detailed the testing process was. I had never really thought about how many things need to line up perfectly for pregnancy to happen.
Yeah, and when we got the results, we finally had some answers. It turned out that my sperm count was a bit lower than average, and Emma had a slightly diminished ovarian reserve, meaning her egg supply was lower than expected for her age.
Exactly. Both male and female factors were contributing to the difficulty in conceiving. In situations like this, we often recommend assisted reproductive technologies, such as intrauterine insemination IUI, or in vitro fertilization IVF, depending on the specific circumstances. In Emma and Luke's case, we discussed the option of IVF, which offers a higher success rate given the combined factors.
The decision to move forward with IVF wasn't easy for us. I think there's a lot of stigma and misunderstanding about fertility treatments. Some people think you can just relax and it'll happen, but for us, it was clear that we needed medical intervention.
Yeah, and it's an emotional process. There's the financial aspect too, since IVF is expensive and not always fully covered by insurance. But once we talked it through, we decided that if this was our best chance at having a baby, we were willing to go for it.
Absolutely. IVF can be an emotional and physical journey, but it also offers hope to many couples. The process starts with ovarian stimulation, where we give medications to stimulate the ovaries to produce multiple eggs. These eggs are then retrieved and fertilized in the lab using Luke's sperm. Once the embryos develop, we choose the healthiest one or two to transfer into Emma's uterus, hoping for successful implantation and pregnancy.
It was definitely intense. The medications, the injections, there were moments when I felt overwhelmed. But Dr. Brookfield and her team were there every step of the way, guiding us through it all. We've gone through one cycle so far, and although it didn't result in a pregnancy, we are staying hopeful and plan to try again.
Emma and Luke's experience is not uncommon. It's important to remember that even with IVF, success is not guaranteed on the first try. However, the overall success rates are encouraging, especially for younger women. We also talk about other factors, such as embryo freezing, which can allow patients to try again without going through another full cycle.
And I think another thing we didn't expect was how much the emotional side of infertility takes a toll. You feel isolated, and sometimes it's hard to talk to family and friends because they don't really understand.
That's an important point. Infertility can have a huge emotional impact on couples, and it's crucial to have emotional support. This is why we often recommend counseling or support groups to help patients cope with the stress and anxiety that come with fertility treatments.
We've started seeing a therapist who specializes in fertility issues, and that's been really helpful. It's nice to have someone to talk to who understands what we are going through, And we are also learning how to better support each other during this process.
It's wonderful to hear that you're both taking care of your emotional health too. Fertility treatments can be challenging, but with the right support, they can also be empowering. We'll continue to monitor Emma's progress and adjust the treatment plan as necessary. Every case is different, but with persistence and care, we're hopeful for a positive outcome.
We are too. It's been a tough road, but we are trying to stay positive and take it one step at a time.
Yeah, we're really grateful to Dr. Brookfield and her team for giving us hope and guiding us through this journey.
That is the end of Part C. You now have 2 minutes to check your answers.